imaging data set. We have some physicians in this room, but not that many. So I wanted to go through an overview of breast cancer, right? So why do we care about breast cancer? Leading cancer cause of death in women worldwide. 1 in 8 women will get breast cancer in their lifetime. Screening mammography is basically a program in which a woman receives a screening mammogram, and I'll talk about what that means, what a screening mammogram is, about every year starting at age 40 and then less frequently as they get older. And that has been proven in many, many studies to decrease death from breast cancer because you can detect cancers earlier and treat them, right? They are unique in radiology imaging in that they are among, if not the, at least the highest resolution that I can think of. It's the highest resolution 2D image in radiology. So these images are typically on the order of 8 megapixels or so. So you'll have something that's around 3000 by 2000 or 3500 by 2500 pixels. And then the other challenge is that the signal to noise ratio in these is amongst the lowest of everything in medical imaging. So I'll show some examples on this at the symposium on Friday. This is a true needle in the haystack problem. So screening mammography screens 40 million women in the US every year, of which less than 1% have cancer. Of those women that have cancer, the cancer is present in one of the breasts, typically not both, so half again. And then of that 8 to 10 megapixel image, your cancer or ability to detect the cancer can be as few as 10, 20, 50, 100 pixels, right, out of 12 megapixels. So you have a true needle in the haystack problem where you have to detect something really tiny that's really rare on a really high resolution image. Okay, this is what makes this very challenging, but also very valuable and interesting. And this is why we wanted to leverage this data set during this datathon, because as data scientists, if you guys understand how breast imaging works, then you can help to design the data engineering and design the models that go into training to detecting cancer. So this is a screening mammography machine. It is an X-ray, just like we saw yesterday, how chest X-rays are obtained. You have a source on one side. You shoot X-rays through the patient. It's captured by a detector on the other side. It is uncomfortable. The woman is typically standing, and their breast is sandwiched between the source and the detector in a plate. The idea is to compress the breast as much as possible so you can spread the tissue out, right? So if you have a breast that's uncompressed, all the tissue inside the breast will be overlapping. The more you compress it, the more you spread things out. Okay, there's typically 2 views that we obtain, a CC and an MLO view. I found this on Google. I think the woman's expression is appropriate because it is uncomfortable, but I found that kind of funny. So CC view, CC stands for craniocaudal, okay? Cranial meaning head, caudal meaning tail in anatomy, so head to toe, okay? MLO is a second view, medial to lateral oblique. So it's a diagonal view, CC view craniocaudal. So you're getting not 2 completely perpendicular angles of the breast, but the idea is you're imaging the breast, one from top down, creating an image, and one diagonally or horizontally, getting another plane. And why is this important? So let me, I want to change the order of this a little bit. I think it's very important to note something about breast imaging and radiology, any 2D imaging in general. We are taking a 2D image of a 3D anatomic structure, okay? That means you're getting a projection of the image. So just like in the chest X-ray example yesterday, you're shooting through the back of the patient or the front of the patient, everything that beam passes through between the source and the detector is represented on the image in a 2D fashion, right? So think if you had a transparency projector. Well, you guys are young, but when in the 80s and 90s, many of you may remember we didn't have PowerPoints. We had the overhead projector, and a lot of teachers would have their base overhead transparency slide, and then they would layer another transparency on top of it to show something, and then layer another transparency, shine the light through, and you'd get on the projector, you'd get the full image, right? So the point of this is, if 2D imaging is meant to detect abnormalities in anatomy, that abnormality can be obscured or confounded by anything else that the beam passes through. So if you have a chest X-ray, if you've got a big pacemaker, anything that is in front of or behind the pacemaker, because the pacemaker is metallic and will absorb all the X-ray, anything in front of or behind the pacemaker will be invisible unless you get a lateral view, which is why we get multiple views. In breast imaging, it means that let's assume that circle is cancer and semicircle is not cancer. Well, in this projection, the X-ray source is up top. You're passing it through two benign semicircles. Because of the way that they're aligned, when you project them into a 2D plane, you get a circle. It looks like you have cancer on the image, right? If you roll the breast slightly laterally, right? If you take an object and roll it, anything superiorly will move to the right. Anything inferiorly, my thumb, will move to the left. My index finger moves to the right. Move them out of the way. Now you can see that they're two semicircles and that they're benign. This is at the heart of a lot of breast imaging that we do, is deciding whether or not the thing that you're looking at is actually an abnormality. Is it a circle, or is it just two semicircles, meaning two benign things projecting over each other? Okay. Does everyone understand that concept? Okay. Question? Oh, okay. All right, so going back. So CC and MLO view. This is a CC view. This is an MLO view. Everything in radiology is reversed. So this breast is pointing to the left. These are actually mislabeled. This breast is pointing to the left, so this is the right breast. I'll fix this. This breast is pointing to the right, so it's the left breast. This breast is pointing to the left. This is the right breast. This is the left breast. Okay? The reason there, so all of this image stops here. So this is one image. This is another image, this is another image, and this is another image. So a standard screening exam has 4 views, okay? It has a CC and an MLO of the left breast, and a CC and an MLO of the right breast. 4 images in a standard screening examination, lots of exceptions to that. The way that the radiologist interprets them is one of the big things that we look for in radiology in general is symmetry. So if something is asymmetric, that's generally a bad sign. Same thing happens in breast. So rather than putting the left CC and the left MLO next to each other, we put the left CC mirrored next to the right CC, and we put the left MLO mirrored next to the right MLO, so that the radiologist can more easily discover the asymmetries. Okay, so 4 screening views. CC stands for craniocaudal, MLO, medial lateral oblique. Perfect. Okay, there are a couple anatomic landmarks. Again, this is just for context here. So on a CC view, it's taken from the top down. This is the inner side of the breast. This is the outer side of the breast. So if I'm the patient, for my right side, okay, the bottom part of this image, the inner side, medially, the top part, outside, okay? That applies for the left and the right breast. So lower part is the inner side. The outer is the lateral side. Medial, we talk medial and lateral. We don't talk about left and right because you would get messed up depending on what side you're on. So medial versus lateral. And then same thing here on the MLO. This is a little bit easier to visualize. So that white triangle, that's the chest wall. That's the pectoralis muscle. So the top of the image is the top of the patient. Bottom of the image is the bottom of the patient. So this little band of tissue here is called the inframammary fold. So that's down here. Okay? So that's orientation. Questions? Okay, cool. So a couple things that are needed. So I'll just talk about this really quick just so you guys have an idea. So the chest wall, these are the things highlighted here, the things required to make a valid mammography image. You don't really need to know this as far as using these images, but just suffice it to say that there are certain quality criteria that make something a valid mammography image, which lends itself really well to machine learning because all of the images are really, really similar. They must contain this. So they must contain a certain percentage of chest wall or a certain thickness of chest wall in yellow. They must contain a certain amount of inframammary fold. They must contain the nipple in profile, and the distance between the nipple and the chest wall on the MLO image should be similar within 1 centimeter of the distance of the nipple to the chest wall on the CC image. Okay, you guys don't have to worry about that, but just so you know what you're looking at. Okay. And this is the underlying reason that you might see multiple repeats. So when we get into the data set for a given exam, you might see 2 left MLOs or even 3 left MLOs. And the reason for that is that the first one or the second one did not meet the quality criteria for the image. And we'll talk about how to handle, Beatrice will talk about how to handle that tomorrow. Okay, cool. So let's do a little practice. So I have a lesion here in green. Anybody want to tell me what portion of the breast this lesion is in? We divide them in quadrants. So your quadrants are upper inner, upper outer, lower inner, lower outer. Very simple. So which breast in what quadrant? And let's for not to confuse you guys, let's pretend these are correct, even though they're incorrect. Let's pretend that those are right. So which breast in what quadrant is this lesion in? Left upper inner. Perfect. What about this? Right outer. Lower. Good. Okay. What about this one? Left lower. That's a trick question, right? These are one's in the left breast and one's in the right breast. Okay. The reason I mention this, though, actually, is because not every lesion is visible on both views. If we're lucky, we get to see the same lesion on the CC and MLO view. But what did I say earlier? It's a 2D projection of a 3D structure. That means that if there's a lesion visible on the CC view, you're not guaranteed it's going to be visible on the MLO view, depending on how the projection is, what other tissue is in the way, right? This is a very fatty breast, and we'll talk about what that means. But this breast is mostly black, okay? Black means fat, means there's not a lot of glandular tissue, right? White is tissue, that's like the muscle we have here, right? Black means mostly fat. So in this case, probably if there was a lesion visible on CC, you probably would see it on MLO. But lots of breasts have dense fibroglandular tissue, which means that if you see a lesion on CC, on MLO view, it could be obscured by the other glandular tissue that's in the beam path between the source and the detector, right? Does that make sense? Okay. This is also very common. There's lots of cases where there's lesions in both breasts. I would say maybe a third of cases that have an abnormality have abnormalities in both breasts. Okay, some special views. You will come across these. So this is an implant displaced view. Women can have breast implants for augmentation, but also for after cancer diagnosis and mastectomy, the breast tissue removed. You may have had surgery, may have had trauma. So these are implant and implant displaced views. So they take one image with the implant in view, then they physically manipulate the implant out of place and take another image. So this is a CC view with the implant visible. This is the same breast, same patient CC view with the implant displaced. Same thing with the MLO. MLO visible, MLO displaced. You don't always get all of it out, right? You don't always get the whole implant out of the way. Important to know why. Why do you think implants matter from a machine learning perspective? Think about the chest tube example. Shortcuts. Be more specific. You can't just say shortcuts and bias anymore. It's an artifact. Okay. Right. So it's a big artifact. And would this be, remember our conversation about random versus non-random? That was about missing data, but let's talk about random versus non-random artifact. So are implants, based on what I said 30 seconds ago, are implants present at random, or are they present in some distribution of women? Right? So some women who decide to get breast augmentation, yes, that could be considered at random. But at least half of women, if not more, who have breast implants that show up for screening have them because they had cancer. So if you start training a model with breast implants and a disproportionate number of women with breast implants have a history of cancer or have developed subsequent cancer in the other breast, the model will learn the relationship between implant and cancer rather than learning that the tissue has cancer, right? So that's why it's important. So you can choose during the datathon to accept or reject these implant displaced views. I mean, the easy thing to do when you have a large amount of data and heterogeneity is to discard them, but you could also craft your datathon project around trying to do something with these images, right? They represent an important and very interesting subset. Okay. Extra screening views, we won't be dealing with these, but suffice it to know they're present. So CC and MLO are the most common screening views, but this is CV, this is a cleavage view. Okay, so you can take a view between the two breasts. Breast tissue can go very far medially, and so if you see something on a normal CC view that you're concerned about, you would get a CV, a cleavage view, to go further medially. Same thing here, XCCM, so exaggerated CC medial. So it's a CC view with exaggerated view of the medial breast tissue. So it's not quite as far as a cleavage view, but more medial. And then XCCL, exaggerated CC view to capture more lateral tissue. Okay, you'll see these views in the data set. You can choose to use them. You can choose to do something interesting with them, or you can ignore them. Okay, questions? Okay, cool. So I alluded to breast density earlier. All right. Breast density, so there's a system called BIRADS, which is the breast imaging reporting and data standards. Okay. It's a way that we report mammograms out in a standardized lexicon with standardized scoring so that they can be interpreted more easily. Okay, so when we talked about, so there's a density scoring from A to D. A is mostly fatty, B is scattered fibroglandular tissue. So fibroglandular tissue is just breast tissue. Okay, so that's fat, it's fibrous tissue like architecture, the ducts that produce milk, and all the stroma associated with that. So scattered fibroglandular density means there's a little bit of it. Heterogeneously dense means it's dense, but some areas are more dense than others, like up there, and D is extremely dense. Pretty much all the breast tissue is fibroglandular. Why does it matter if somebody is fatty versus dense? Yep. Yep. Everybody hear that? Tumor masking, right? So in a dense breast, it's harder to see a tumor because X-ray is a measure of density, right? X-ray just displays density. There's 4 densities in X-ray typically. Air, which is the complete black around the image. The next most dense is fat, which is the black part of the breast tissue. The next density is water. That includes water, vessels, arteries, veins, muscle, cancers, and anything that approximates soft tissue density. And then the last one is metal or bone, right? You could maybe consider 5 densities. Okay, so cancer tissue is tissue. It gets masked by the fibroglandular tissue in the breast. So here I have these stars. They're all exactly the same. I copy pasted the little shape. Okay, look how hard it is to see that star of the exact same color and intensity on the dense breast, right? This is actually exactly what the problem is in breast imaging, right? Is that cancer gets obscured by the surrounding tissue. Okay, questions? All right, so BIRADS lexicon, you'll come across this in the datathon. This is all the stuff that's available for radiologists to describe breast imaging. If they see a mass, so they'll describe the composition, which we talked about, fatty, scattered, heterogeneously dense, or dense. If they see a mass, they'll describe its shape, margin, and density. If they see an asymmetry, which means something that's asymmetric from the other breast, they'll describe it. If it's global, like the whole breast is different, or if it's just focal. Architectural distortion means that there's something that I can't see, but it's distorting the surrounding breast tissue. Calcifications, what pattern are they in? Like what shape are they? How big are they? What distribution are they in? Okay, do they follow the distribution of ducts? Do they look coarse? Do they look pleomorphic? You don't have to worry yourself about the nuances between these besides to know that this exists, right? This language or lexicon exists and it's detailed in the data set, and certain findings are buzzwords for cancer, right? So if I see pleomorphic calcifications in a segmental distribution, that's like alarm bells for cancer. Or if I see a irregular mass with obscured margins of high density, alarm bells for cancer. If I see an oval mass with circumscribed margins with equal density, it's probably benign. It's a fibroadenoma. Okay, so the reason for this lexicon is so radiologists can describe things and send them to biopsy and justify what they saw to justify the biopsy to potentially detect the cancer. Okay, there's also an ultrasound lexicon as well that's similar, but ultrasound findings are different than mammography findings. Okay, BIRAD score. This is probably the part that will be very relevant to you guys, so I want you to just pay close attention here, okay? So BIRAD scores are meant to relay the suspiciousness of that exam. Okay, so BI-RADS goes from 0 to 6, and typically the higher the score, the more suspicious the finding. Okay, for screening on the left, you can only assign a BI-RADS 0, 1, or 2, and for diagnostic on the right, you can assign a BI-RADS 1 through 6, and I'll explain why. So a screening exam is those two standard CC and MLO views the patient actually leaves. They go home later on that day or the next day, the radiologist reads a scan. If they see something suspicious, the patient comes back for their follow-up. So if you see something suspicious on screening mammography, you actually give it a BI-RADS 0. And it's a subtle nuance, but the key is that the radiologist is seeing something suspicious enough to call the patient back for more imaging. Okay, so that means they came for screening. I saw something. I don't really know what it is yet. I can't say it's cancer or no cancer, but I'll describe it, and I'm going to bring them back for a diagnostic exam, which includes more views and more imaging, which I'll show, to help figure out what this thing is. Okay, or if they find that it's nothing, if they look at the screening exam and they say that I don't see anything concerning, they'll assign it a BI-RADS 1, meaning negative, means I saw nothing, or BI-RADS 2, which is benign, meaning I saw something, but I know the thing that I saw is benign. So for example, I see an old scar from a previous resection that hasn't changed for the last 2 years. I know it's benign. So I didn't see nothing, but I saw something that I'll talk about, but I'm not worried about that thing. And those patients that get BI-RADS 1 and 2 come back next year. Patients that get BI-RADS 0, they come back usually within a few weeks to get their diagnostic imaging. So on diagnostic imaging, the thing to know is that you can get a BI-RADS 1 or 2. So you got, let's say, so you only get diagnostic imaging after screening. If you get, and I'll run through this, if you get a BI-RADS 0 on screening, you'll go to diagnostic, okay? So of those patients that get diagnostic exams, you're evaluating what you saw previously with additional views. Once you evaluate it further with additional views, you can assign it a BI-RADS 1 or 2. You can say that that was superimposition. Remember that example of the circle becoming two semicircles? You got an additional view of the breast. What you thought was abnormal is no longer abnormal. It's negative, or I still see something, but getting additional views, I know that it's benign. So 1 or 2. Or you can assign it a 3 through 5, right? Which is increasing levels of suspiciousness, okay? 3 through 5, 3 will be followed up every 6 months, 4 and 5 go for biopsy, 6 is a special edge case that we don't really need to be worried about, okay? And I'll show this sort of in a graphic, courtesy of Beatrice, okay? So we'll run through this one more time. If you learn one thing from this lecture, try to learn this, okay? So, asymptomatic, where's that little pointer? Okay, asymptomatic patients go to screening exam every year, okay? 90% of those patients are negative or benign. They get a BI-RADS 1 or 2, and they go back to regular screening. So, 1,000 women get screened, 900 of them are BI-RADS 1 or 2, they return to screening. Make sense? Okay. 100 of those women get a BI-RADS 0. That means the radiologist saw something abnormal in the screening study. They want to evaluate it further. We call that a callback or a recall, and they come for a diagnostic study within a few weeks, okay? So the two ways to get a diagnostic exam are from screening exam that was abnormal, BI-RADS 0, to diagnostic, or screeners are only in asymptomatic patients. That means I'm not experiencing any symptoms, discharge, pain, nothing. As soon as you have a symptom, you are not eligible for screening. So two types of patients get diagnostic exams. The asymptomatic patients that went through screening, radiologist saw an abnormality and went for diagnostic, or let's just say you started experiencing breast pain, you go see your doctor, you'll go straight to diagnostic, okay? From diagnostic, so let's go with this screening paradigm. 1,000 women get screened, 900 go to BI-RADS 1 or 2, 100 get BI-RADS 0, they go to diagnostic. Of those 100, about 60 of them are assigned BI-RADS 1 or 2 on the diagnostic. Those patients go right back in the screening pool. So we saw something suspicious, we took a closer look at it, it's nothing, return to regular screening. So that leaves us about 40 patients, okay? Of those 40 patients, maybe about 5 of them get a BI-RADS 3, BI-RADS 3 means I see something I don't think is bad enough to biopsy, but I also don't want to image them in a year. I want to image them every 6 months for a few years to make sure the lesion's not changing. That's BI-RADS 3. And then about 30 to 35 will get a BI-RADS 4 or 5. They'll go to biopsy. Okay. If the biopsy is benign, then guess where they go? Back to screening. Okay. If the biopsy is a high-risk lesion, which I'll talk about, or non-invasive cancer or invasive cancer. So invasive cancer is worse. It means it's invaded the surrounding tissue. Non-invasive cancer means there's malignancy, but it hasn't spread into the surrounding tissue. Either of those will get resection. Okay. Resection can be a lumpectomy or a mastectomy, which we'll talk about. Okay. So if you start with 1,000 screeners, 900 are negative, 100 go to diagnostic, 60 of those still are negative after that. Of the 40, about 30 or so get biopsied, and of the 30 that get biopsied, 10 of them have cancer. So 1,000 women screened, 10 cancers detected on a good day, right? So lot of data imbalance. Okay, I'll just talk briefly about types of abnormalities. So this is a mass here. Okay, so this is what I'm talking about. This is a fairly obvious mass, believe it or not. This is the size of abnormalities we're talking about. Okay, these are very obvious calcifications here and here. Most times they're much smaller. On Friday during the symposium, I'll show some examples of very tiny calcifications that are missed by AI models. And then this is an architectural distortion. So this is not a mass that's seen, but something is distorting the surrounding breast parenchyma. So just so when you see these words, you kind of know what we're talking about. So masses, asymmetries, calcifications, architectural distortions. So let's take that BI-RADS 0 patient. Let's take him to diagnostic. These are some examples of diagnostic mammograms. So typically you repeat the CC view or repeat the MLO view from screening, and then you start doing these special views. So this is a compression paddle, and as you can see, it's meant to compress the breast even more and get a better look at the abnormality, right? So we have them defined as special views in the data set. This is a spot paddle. So they put a paddle on the breast, compress it with the idea of this was the they saw some density here. They want to move all the other tissue out of the way so they can get a better look at that density. So this is what happens during diagnostic mammograms so that the radiologist can make a decision of whether or not to biopsy that lesion. Okay? Let's say that you see it, you get a BI-RADS 4 or 5. So let's say this thing still looks suspicious. We biopsy it. Okay, this is what a biopsy looks like. You can do an ultrasound guided biopsy, which is shown here. You can do a stereotactic mammography guided biopsy, basically getting a piece of tissue, right? And then if that tissue returns invasive cancer, non-invasive cancer, or a high-risk lesion is a lesion that will have about a 10% chance of becoming cancer, then you go ahead and resect the lesion. So you can do a resection where you just take the lump out. This is called a lumpectomy. Or you do a mastectomy, depending on its invasivity and other features, which we don't really have time to get into. You'll remove the entire breast. Okay? Brief word on artifacts. We talked about it. So some artifacts that you'll come across. This is a scar marker. This is on the skin of the patient. So if patients had prior surgery, they'll actually put this radiodense piece of tape on the skin of the patient to mark where the scar is so that you don't confuse an abnormality on the skin with an abnormality in the breast, right? Because when you look at that 2D projection of a 3D structure, you don't know if what you're seeing is on the skin or inside the breast. Point in case, a mole marker. So lots of moles, if you don't know it's a mole, will look like a mass inside the breast. So we put mole markers on the skin to say that whatever is inside of this mole marker, if I see a circle or a dot or any abnormality that looks like a mass, I know that it's on the skin and not in the breast. These are biopsy clips. This is a pacemaker. So these are the sort of artifacts that we will see. So powerful tool for cancer detection. Very high resolution x-rays, very low signal to noise ratio, and you should be very aware of confounders, which we'll talk about over the next coming days. So questions? Yes. So It's both cost and feasibility. Okay, so an breast MRI takes 30 to 45 minutes plus the time to position the patient. So a single breast MR machine, you can probably do 10 or 12 breast MRs a day. Mammography centers typically do about 250 patients a day. So there are not enough MRIs in the world to screen women on MRI. That's a very simple answer. Beyond that, MRI is more uncomfortable. There are more contraindications to MRI of women that can get MRI. And then lastly, it's also extremely expensive, right? I mean, if um, an MRI, I don't know the exact number, but if I had to guess, probably 10 times as much or maybe 20 times as much as a mammogram. So it's just not feasible for those reasons. Great question. Yeah.
The signal to noise ratio vary depending on the device we're using.
No, I mean, yes, some devices may be noisier than others, but on average, they're held to very high standards, like MQSA standards. So there's a certifying body that certifies the monitor, the devices themselves, how often they're calibrated, how often they're checked. You have to calibrate them with phantoms with known density and known tissue, known abnormalities. The monitors have to be calibrated and checked, right? So it's so the signal to noise is not in a traditional sense of like digital signal to noise. I mean it more in the sense of like cancer is really tiny it's like a needle in a haystack, probably more accurate. Yeah. Yeah, so we'll talk about that when we talk about the structure of the data set. So for example, a given screening exam has 4 images, and there's a patient identifier, but there's also an exam identifier. So you know that within this exam, this patient came on January 1st. Here's their right CC view, their right MLO, their left CC, left MLO over for that exam. Then you can go to the next year and see their next exam. So it's all, was that your question of like how to identify the views? Yeah, so ideally, so the question is, you may have 10 different X-ray machines at Emory. We'll probably have 40, right, for mammography. Some will be, all of ours is actually a downside. Almost all of ours are Hologic, which is a brand, but you need your model to work on GE scanners and Siemens scanners and Toshiba scanners, and all of them do have different noise profiles and different artifacts in the image that we as humans probably can't pick up, but machines will definitely pick up. So it is a known phenomenon that in medical imaging, if you train all of your model on one manufacturer, if you train your model on GE chest x-rays, it will perform worse on Siemens chest x-rays because it's not seen it before. As a human being, when I look at a chest x-ray, I can't tell what manufacturer it came from, no more than I can tell what race the patient was, but machines can pick up those subtle differences and patterns just in the noise and the detector and whatever else it might be. So in general, you actually want to have data from multiple scanners and multiple sources when training and validating. I know there's one more question. The naming convention for. Oh, sure. Yeah. And I will post these slides, but basically, was it this one? Like the outer inner. Yeah. Okay. So on a CC view, right, the top of the image is the outer breast, the bottom of the image is the inner breast. Let's go to a real one. Okay. And then on the MLO view, you have the top of the image is superior and the bottom of the image is inferior. So if I have a lesion that I see here and here, this is a lesion in the right breast in the outer quadrant because it's at the top of the CC view. So the top of the CC view is the outer portion of the breast. So by outer, I mean closer to the arm. Okay? So if you're on the left side, outer is this way. If you're on the right side, outer is this way. So closer to your arm and inferior. So just lower versus upper. So this lesion, if I see the same lesion Here on CC view and here on MLO view, it would be in the outer portion of the lower right breast. So it's just a quadrant system on mammography. That's as close as we can get, given that you only have two views. Yeah. Yeah, so why not use nuclear imaging that goes and localizes the tumor? So that does exist. They're not feasible for screening. But we do use nuclear imaging for when patient has a known cancer, you want to detect where that cancer has spread. The problem is if you use that in screening for a lot of women, cost and time. So nuclear medicine scans take a couple of hours. Sometimes you have to inject the patient, you have to wait, then you have to image them. So the throughput is not high enough. The second problem is that they're very non-specific. So if you were to use FDG imaging on, so nuclear medicine is only as valuable as the specificity of the nuclear tracer, the biological agent, to whatever you're looking for, right? So when we look for tumor metastases, we use glucose, right, FDG. That will go to any metabolically active site in the body, which includes tumors, which is good, but also includes your muscles if you've worked out or eaten, also includes fractures, also includes basically all of your kidneys and all of your brain, right? There's too many confounders in nuclear imaging to use it as generally as a screening test because people will be lighting up everywhere for things that are not cancer. Yeah, I mean, I see your point, right? The immune system will go to the site of abnormality, but it's unfortunately not that cut and dry, right? I mean, that's the way it's taught, but there are so many other physiologic processes happening where that tracer would localize. Yes, question. Yeah. Yeah, so Theo will talk about that in his talk a little bit on pre-processing. So you can harmonize the images across scanners to have the same distribution of pixel intensity and histogram and cropping out the breast tissue. But there is this imperceptible, very high frequency, fine, random noise that is like a fingerprint for certain scanners. And you could take um, a cohort of maybe just a couple thousand mammograms and label them with their manufacturer, GE Toshiba Siemens, and train a model to detect what scanner it was, and it would do a very good job. There's this imperceptible fingerprint in the images that we don't know how to um, eliminate, essentially. You had one more question? Yeah. Yep. Yes. Yes. Yeah. So that's a great. So this is we will talk about this over the next couple days. We're going to talk a little bit about MRI on Thursday. So the question was, are there women that instead of after their BIRAD 0 and screening, instead of going to diagnostic mammogram, they go to diagnostic ultrasound? And the answer is yes. There are many lesions which are better seen on ultrasound than they are on mammography. And that presents a challenge because you're labeling the mammogram with cancer, presumably because it was a screen detected cancer. So it's visible, but it may be more visible on another modality. And that's something that we'll touch on Friday. Question? Oh, that was a mole marker. So that represents, yeah, so that circular sticker is, here's one. That's a mole marker. So that means there's a mole on the skin. Um, and it's hard to tell, but there's a tiny little abnormality here. If I didn't have that mole marker and I'm reading the scan, I would think, okay, maybe there's a lesion there. I need to get a diagnostic exam, right? So this lets me know that whatever's in that circle is actually on the skin and not in the breast. So the question is, does the period of time when the X-ray was taken matter for training the model? Do you mean like the time of day, or do you mean the like time of? I see. Yeah, so that's a great question. So the question is like, does the age of the X-ray matter for its ability to be able to generalize to new images? And that's a really good question. So we are collecting retrospective data sets. The embed data set goes back about a decade now, right? And so it's a little bit of an unanswered question of if more recent images are more valuable for training the model than older images. Um, it's There's too many factors to give a blanket statement, right? Obviously, after a certain point, technology improves enough where the old images really just don't represent the current images anymore. I'm saying X-ray and mammography, we converted to digital for most of radiology in the last 2 decades. Anything that's newer than 15 years old is probably still reasonable and valid for training, but there is a lot of work that I've seen around, you know, testing models trained on 2013 to 2018 data and training it on 10-year-old data and testing it on 2-year-old data, or if trained on 10-year-old data and testing it prospectively, does the more recent data perform better than older data? um, we don't have the luxury of being picky, right? If we had to mine 110,000 women to find 3,000 cancers, right? So if we start getting picky on the age of the scan, that will continue to dwindle. But it's a very good point. I would say largely it's unanswered unless somebody else in the room, knows something different. Okay. All right. We're at time. We have one more talk, which is the introduction to embed. I think what I'm going to do is, I don't know, Judy stepped out. Um, let me give you guys a brief primer. Um, we'll keep it to like 15 minutes because I want to explain this data set when it's fresh. And maybe Beatrice, tomorrow morning, I will just repeat it. I think if you let it soak in a little bit overnight and then come on it, you'll have time to digest it. But I don't want to get too far into it because I'm fried. Everybody's fried. It's hard to learn something brand new, but I feel like while this is fresh, we should at least touch on the data set so you guys know what it is, and then we'll try to be really hands-on tomorrow.